Everybody hear me okay?
Yep, we can hear you and see your screen.
I had my speakers off. It's not going to help. Okay. We good to go?
Yep, you're good, Katie.
Okay, great. Well, thank you guys. Thanks everybody for joining us today to the webinar entitled #AskMeAnything, Transitions of Care in Solid Organ Transplant. This webinar is supported by the ACCP Immunology and Transplantation PRN and the American Society of Transplant Pharmacy Community of Practice. My name is Katie Cunningham, and I am a transplant pharmacist at Northwestern Memorial Hospital in Chicago, Illinois. I practice in abdominal transplant and lung transplant, and it's my pleasure to be here today. In a moment, I'm going to turn it over to our panelists to start our presentation, but just a few notes before we get started. For our audience members, please make sure you're muted for the duration of today's presentation. The mute button's in the lower left-hand corner of your screen. If at any point during the presentation you have a question for any of the speakers, please submit them in the chat, and you can submit them directly to me. And then at the end of the presentation, I will kind of go through the questions and then we'll present them to our panelists. This webinar will also be posted on the ACCP IMTR YouTube channel. And if you experience any technical difficulties like I already have during the webinar that aren't fixed by logging out and refreshing your internet, please try to chat me and I'll try my best to help you. And without further ado, I will turn it over to our panelists so they can introduce themselves.
Thank you, Katie. Hi, everyone. My name is Khalil. I'm a clinical pharmacotherapy specialist in abdominal transplant at NYU in New York City. I work with kidney, liver, and pancreas transplant patients on the inpatient and outpatient side. And I'm particularly passionate about improving access to medications. And I'm really happy to be here with you today.
Thank you, Karen. Go. Oh, I went too fast.
Hi, good afternoon. I'm Kristen Belfield. I'm a clinical pharmacy specialist at Yale New Haven Hospital in Connecticut. I cover our adult abdominal organ service and transplant and rotate between the inpatient and outpatient clinic. Probably what I love most about my job is our ability to manage our patients through a collaborative practice agreement, which really sees them through from the time of evaluation to post-transplant. And I'm really grateful to work with a really great team of both pharmacists and providers.
Thanks, Kristen.
Hi, everyone. I'm Marissa Brokhof, and I'm coming to you from Chicago, Illinois. I'm a clinical pharmacy specialist in abdominal transplantation at Rush University Medical Center. I do a rotation of inpatient, outpatient, and everything kind of pre and post relating to those organs. I love my job. I love my colleagues. I love my patients. And I like that every day is a little bit different and keeps me on my feet.
Thanks, Marissa.
I'm Dan Felix. I'm a clinical pharmacist in abdominal transplant at UW Health in Madison, Wisconsin. I care for patients in both the inpatient and ambulatory care settings, mainly kidney, liver, and pancreas transplant recipients. And similar to what others have said, I like the exciting days that we have. Like no 2 days are the same here, just like Marissa mentioned. And I do like the complexity and the variety of medical issues that we see in our patients.
Thanks, Dan. Oh.
Hi, everyone. My name is Justine Dickson. I'm a clinical pharmacy specialist at Boston Medical Center. A little bit unique. I'm an ambulatory care trained pharmacist. Prior to BMC, I had 0 experience in transplant. We have a smaller program in Boston, and so I'm only focused in the outpatient setting, kind of utilizing my ambulatory care knowledge and bringing that to the transplant clinic. So I don't rotate inpatient, although they would love me to, and I'm terrified. So heads up for all of you guys. I give you guys a lot of props. Nothing I can do anymore. a lot of what I do is mainly focusing on the pre-transplant evaluations and identifying a lot of potential for non-adherence and barriers. And what I really love about my position at Boston Medical Center and just BMC as a whole is the wide variety of patients that we care for from a very diverse setting of backgrounds and from really all over the world. So definitely also keeps me on my toes and new things that I have to try and trial and be creative about every single day.
Thanks, Justine. All right, well, now that we've gotten to know our panelists, we're going to start out with a question for all of them. And we're going to ask them about what unique transitions of care initiatives have been implemented at your institution. So we can start with Karen.
Sure. So something that's unique at NYU is we actually have a specific person who's dedicated to transitions of care and discharge, a nurse by training who has a background in education, who, you know, we work closely with in terms of medication teaching as well as, you know, discharge preparation. And it's definitely someone that we rely on heavily. As we all know, you know, prepping someone for discharge, especially right after transplant, is a big feat. So it's something that I think is very useful.
Sounds amazing. I already have questions for you about it. Okay, Kristen?
So at Yale, I'd say we have two transitions of care initiatives that have really benefited us. So the first in 2016, we opened a health system specialty pharmacy where we have 2 dedicated transplant pharmacists, pharmacy technicians, a whole PA team, as well as a medication assistance team. So since 2016, we've really relied on them to ensure access to our patients pre and post transplant for medication and basically troubleshoot any issues that we have. I have no idea what we did prior to 2016 without them. The second thing that we've done is we've created within our EMR a way to communicate between pharmacists in the outpatient setting. So we use Epic at our center, and we have been able to customize something called a My List to allow for actually direct pharmacist communication, which I'll talk about a little further.
Great. Marissa?
At Rush, we're really working to dedicate more of a focus to the pre-transplant setting, or the setting of evaluation to listing and listing to transplant, with the deceased donor waitlist in Chicago being 5, 6, maybe even up to 7 years. Some of these patients sit for a while. So we're trying to go kind of heavy with a pre-transplant pharmacologic evaluation and annual visits. If there are remote contraindications or concerns, what kind of corrective action or follow-up should go on to get the patient listed for transplant. And we're trying to see them every 2 to 3 years while they remain on the list.
That's great. Thank you. Dan?
We also have a technician group that we work with heavily for transitions of care. We've had them, I think, since 2012 or 2013, where they do all of our test claims for new transplant patients who come in. And then also for any new medication that we are concerned about copays, they assist with us with completing the prior authorizations as well, and signing up patients for patient assistance programs or other ways to save money for patients, such as grants and whatnot. So we rely on them heavily, and they've been extremely fundamental in improving patient access to medications post-discharge.
For those of you that don't know, I did my PGY2 at UW, and I still talk about the technicians and how much I miss them. They're so great.
Same.
Right? Yeah. Thanks, Dan. And Justine?
So I'd say we have a pretty comprehensive program from me evaluating them pre-transplant. We do evaluate them every single time they come in for their evaluation. So it's usually every year or every other year, depending on how early they are in their transplant evaluation process. Anytime we're evaluating any concerns for non-adherence, I'm usually following up with dialysis. I'll have them return back and pre-fill a pill box for me so that they understand, or I might make a med action plan for them or something to help identify what those barriers are, switch them to a different pharmacy depending on their insurance, et cetera. At the time of discharge, the inpatient pharmacist will use a fake medication, like beads to help fill a fake pill box before they can get their discharge medications. We discharge them using our pharmacy, and we give them a tote bag, which has a blood pressure cuff, pill box, pill cutter, and all those things as kind of the paid out of the budget from the department, just the price of doing business, since we continue to fill their medications afterwards. And then I see them post-transplant for all their visits with the surgeon until their transition. Then it's kind of on a PRN basis. So we also have the pharmacy technician that'll identify and submit any prior authorizations at the time of when we receive the email that they're getting transplanted. So she starts that process so that at the time of discharge, we've got everything under control.
I also have questions about the beads. That seems really cool. Okay, thank you guys. And we will move on to our first kind of area that we're going to focus on. I can get this. So this first area will really focus on the index hospitalization for the transplant versus readmissions and how our transitions of care may differ between these. So the questions we'll ask our panelists is the transitions of care process different for that index transplant hospitalization versus a readmission? How do you go about identifying which patients you think need transitions of care? And then is there an expectation for communication or a time frame that patients are then followed up with either by call or seen in the clinic? So we'll start with Marissa.
So at Rush, the transition of care process for the index transplants versus a transplant readmission is pretty similar. There's definitely still the medication reconciliation, the monitoring with the multi-D team during their stay, and then the discharge medication reconciliation. The big exception for us between the two is the overall quantity of the patient education and the discharge counseling, and then often the duration or frequency in which they're following up. Immediately post-transplant, it's nice to have tighter control. You're seeing them and laying eyes on them twice a week for the most part, whereas someone who's just readmit for, say, a resistant or more complicated urinary tract infection might not be seen for a week or two. What about you, Karen?
Yeah, I mean, just to echo kind of what you said, Marissa, I would say that the transitions of care are similar, but definitely for the index transplant admission, I would say heavier on the education side. Of course, they need, all their medication education, their lifestyle education, and, we, with their initial admission, we get all their medications filled and delivered. They will fill a pill box before they leave. So it's definitely a much more extensive process with their index admission. When they're readmitted, it's going to be dependent on, their reason for readmission. So if we identify a gap in knowledge or the need for reinforcement education, then we'll emphasize that. But everyone will get kind of as Marissa mentioned, admission med rec, discharge med rec, med list, and, any prescriptions that they need would be sent regardless.
Yeah, I know for us too, we try, if we change immunosuppression, that's one flag that'll jump out, where then we'll try to target them for education on discharge. So kind of along with that, Marissa, how do you then identify patients?
So criteria definitely include all fresh organ transplant recipients. And that's, as I said, for several clinic visits due to just the complex nature of the medication regimen. It also could be recent rejection, recent infection, definitely, like you said, transitioning immunosuppression, maybe anticipated drug-drug interactions or side effects, definitely history of noncompliance or confusion with the medication regimen. The transplant pharmacy group here at Rush is definitely kind of on consult basis to the outpatient pharmacy team to just work on immunosuppression issues or any other problems identified by the multidisciplinary team.
Yeah, I would say it's definitely similar for us in terms of identifying who needs that additional, help and the transitions of care. One thing I'll add is that for us, for any of our patients who are fresh transplants, their index transplant hospitalization, we'll write a discharge note, which is kind of, communication to a pharmacist on the ambulatory side. We actually only recently expanded to ambulatory. So earlier we were writing discharge notes that were kind of supposed to be our transition to our, NPs in the clinic, but now it's, kind of pharmacist to pharmacist with kind of the things that we want to follow up on, whether it's blood sugar management, blood pressure management, reinforcement of education in the clinic. So that's kind of how we communicate that to one another.
Great. And do you guys, either of you, have any expectation for the time frame that you would follow up? Is it patient dependent?
With a fresh transplant, it's almost always within 48 hours. They will be seen in the transplant clinic on site for a visit by the multi-day team. We do not do phone call follow-ups per se. As I said before, for a further out readmission, they could be seen, weeks in advance.
Yeah, I would say for us, it's something that's unique with our discharge coordinator's role. For every patient who's admitted, they'll get within 48 hours, they'll get a follow-up phone call to see how they're doing and see if there's any issues. And in terms of their follow-up, most of our patients would be seen at the next available clinic visit. So if they're fresh transplants, on a Tuesday or Wednesday that's coming up. And then if we needed them to get labs sooner than that, whether their tax not therapeutic or something else is going on, we would do that and then send them to clinic for the following week. If they're further out from transplant and you just need follow-up in terms of, after they complete their antibiotics or something else, we would probably push out their visit, but they might get labs sooner.
Sure. Is that discharge coordinator? You said that's an RN?
Yeah, RN with a master's in education.
Okay. Is it the same person all the time?
Yeah, so she covers, our whole abdominal side, which is, a big, I guess, population, a big volume. So we're trying to get her help. So we did hire a nurse practitioner who's supposed to assist as well, but it's
great. Thank you guys. Okay, we'll move on here to, and we'll still be with Marissa, and then we'll have Kristen joining in and we'll talk about documentation. So for your transitions of care, what type of documentation do you use in your medical record? And then have you done any special configurations with the EMR to make the transitions of care from inpatient to outpatient more seamless? And then how do you hand off pre-transplant pharmacy issues to the post-transplant setting? So Marissa, if you want to kick us off.
So as of the past 8 or 9 years, all transplant discharges are completed by the transplant pharmacist, just due to the overall vulnerability of the medication regimen in our population. We write a formal discharge note. This includes background information. It includes induction and immunosuppression and prophylaxis regimen, all discharge medications, including where each are coming from, if that varies. And then any pharmacologic issue that needs to be addressed and whether or not the transplant pharmacist needs to continue to see them outpatient. This then in turn serves as handoff or the pass off to the outpatient clinic pharmacist. And as I said, it's been our process for about 8 or 9 years now, and it's been very accepted by the transplant program and team.
Great. So go ahead, Kristen.
Perfect. So, I'd say our process is similar to Marissa's. So we, on the inpatient side, our transplant pharmacist typically documents 3 times on any new transplant recipient. So we have an initial note that basically is saying that we're aware of this transplant recipient, and we go through all of the induction, plan for immunosuppression, plan for infection prophylaxis, and then anything notable about this patient. And then we typically counsel at least 2 times prior to discharge. So you'll see 2 more notes of each of our counseling session, and with the final discharge note having anything notable in it. Those are what formally go into our EMR. Instead of using just a generic progress note, we were actually able within our EMR, which I said is Epic, to create a specific pharmacy transplant type note. So this has been really helpful because any of our pharmacists can filter by this note type and easily find any of these notes. Technically, you could filter just by like a pharmacist writing a note, but then you'd pull in all other pharmacist types. And then we also use a lot of learners. We have fourth year APPE students. And so they write a lot of these notes, even though they're co-signed by us, they still show up as the author. So they wouldn't necessarily show up if you just filtered by pharmacists. So it's really nice to have this specific note type. And then the second thing that I mentioned is that we use something called MyList. So if you're not familiar with these are basically lists of specific patients that you can create that can be shared amongst users, and they can be customized. So we've actually created this whole workflow from inpatient to outpatient with the use of these lists, which I think, expand on a little more with the next question.
Awesome. Well, if you want to go ahead and that, or we can bounce back to Marissa.
Yeah, go ahead. I'm always interested in hearing those cool initiatives within Epic of ways you can monitor patients.
Yeah, so with these MyLists, there's a lot of things that are already pre-built, columns that are pre-built. So, you can pull in things like name, date of birth, data transplant, type of transplant, things like that. But you can actually also customize these. So what we've done is we've created a transplant pharmacy column with a customized transplant pharmacy MyList report. So within this report, it actually pulls in all of our recent transplant pharmacy notes, again, which is really helpful to have that specific note type. It pulls in current medication lists, and then it pulls in pertinent labs that we want. So we pull in things like serum creatinine, you can pull in things like CMV PCR, TAC level, really anything in Epic you can pull into this report. So what's nice is as we're reviewing these patients, often we don't actually even have to go into the patient's chart. We can use this report. So it makes our process a lot more efficient. And then the transplant pharmacy column, it shows a date. And what we do is we use this date as the next actionable date that the outpatient pharmacist needs to act on this patient. So it can be the next date they need to review the patient, the next date the patient has an appointment, or if we have to call the patient or do like a telehealth visit. So it makes it really nice that at the beginning of the week, the pharmacist will review all of our MyLists, make sure that the date is accurate for the next actionable time, make sure that they have any scheduled appointments. And then just on a daily basis, all the outpatient pharmacist has to do is filter by date to see who they need to act on that day. And then attached to this column is also a free text. So a blank space where the pharmacist can free text anything in. So this is what we use for our actual communication between inpatient and outpatient. So typically we'll put like just a brief summary of the patient, and then you can put in anything else that's pertinent. So, for example, if we have a patient who only wants to be called between 9 and 10 a.m., we can put that in that free text. And the pharmacist outpatient always reviews this report prior to calling or seeing a patient. So they're unlikely to ever miss anything that's in here. So it's a little tricky to find ways to communicate in Epic in the outpatient setting. So this has kind of become, if you're familiar with Epic, almost like our outpatient ident that stays open and is viewable to anyone who has access to the list.
So do you guys put everybody on? Is it just people you identify inpatient that you think need follow-up then?
Yeah, so what kind of our workflow is on the inpatient side, we don't necessarily see every single patient like Marissa talked about outpatient, although we probably should at their first appointment, but we're not currently. So we're basically identifying and targeting patients for different things that we're following. So we do hyperglycemia, like site dose adjustments, conversion to things like Envarsus or Bella. Those are some of the main things. So it's the inpatient pharmacist prior to discharge. It's part of their kind of discharge checklist that any patient who has any of these requirements, they add to the MyList. So what's nice though is that the inpatient pharmacist, like there's no need for any verbal handoff really anymore, because once the patient's added to this MyList, the outpatient pharmacist is going to see them. So it's really unlikely that any of these patients will ever be missed. We often still do verbal feedback just kind of as a courtesy and because we're often seeing each other. But like, for example, like if I had gotten verbal feedback and then I was out sick or something, that my list still has the information in it. So whoever's covering me for the day is still going to see that. So it's really made like our follow-up much more efficient and making sure that we're actually seeing all the patients that we need to see.
Sure, that's great. Thank you. How about you, Marissa? Anything you guys?
That's really cool, Kristen. I do not have anything as interesting in that coming out of Rush. We use general notes templates that are very similar in formatting from the inpatient handoff to the outpatient clinic follow-up, so that updates can easily be made. We can continue to track them as well. You know, we rely on really strong pharmacist notes and handoff to close the gaps between these transitions so that there's kind of a lack of miscommunication that occurs. But nothing is interesting in what you guys are doing. That's very cool.
Marissa, it sounds like you guys see a lot of pre-transplant patients though. So is there any specific handoff for pre-transplant issues for post?
So a lot of that is note-based as well. We usually are having or bringing forth discussion with our multidisciplinary team during selection meetings, documenting within the electronic medical record, sending staff message to our transplant pharmacy pool, trying to kind of close the loop on, you know, is this patient a candidate? Are they going to be able to handle and successfully live with a graft? Or is this someone who maybe we identify as needing a little bit more hand holding or work, or, you know, is this person going to fly? Are they good?
Great. And Kristen, do you guys use your list for pre to post or?
So right now we really only use them for our post follow-up. So on the pre side, we do the kind of the same thing as Marissa. We see everyone at evaluation, and then we have a waitlist clinic for our kidney patients in particular, where they're seen typically at least probably like every 2 to 3 years. So we just do kind of progress notes in the chart where at the time of transplant or an organ offer, we can go back and filter by that note and review those notes. But we don't have, the only really active kind of follow-up on the pre-side is we do like vitamin D monitoring for our pre-liver patients. And then we have had hyperglycemia patients that we've monitored on the pre-side, but most of the issues are, like Marissa said, come to kind of at time of listing if we're identifying anything, and then would follow up at time of transplant based on what we've documented in our note.
Awesome. Well, thank you guys for all that interesting tidbits. So we're going to move on to education, focusing on our medication education and talking about the role that the pharmacist versus the technician play in education and the discharge medication access. And I know Dan alluded to this a bit in his intro, so we'll start with him.
Definitely. So we utilize technicians a lot for identifying patients' medication coverage and essentially cost of medications post-transplant. So we'll actually, if we're starting at their like first day surgery visit for some of the living donor recipients, we'll actually screen them for certain high cost medications. Like if they're going to get Valsite, we'll send that off to our technician group to see what the cost would be. And if it's a very, very costly or cost prohibitive, we'll actually start the patient assistance program at that point, just so that potentially doesn't delay discharge and we get patients approved quickly. And then once any transplant recipient is admitted for their index transplant, we will run test claims on all of the immunosuppressants, anti-infectives, even some common medications. The kidneys will throw in Varsis just so that we have that documented if needed within the next few months post-transplant. And the coordinator, not the coordinators, the technicians will then follow up with the patients and discuss their cost of their medications. That's also when they'll discuss coverage issues, discuss if they have like an Optum contract that they have medications at one pharmacy for 3 months and then they have to switch to another pharmacy, or if they have specialty requirements. They'll also introduce our mail order pharmacy services and see if they can capture patients there so that they can use our own UW mail order services. And then they'll also be instrumental in figuring out what to do if we can't get overrides and patients have to fill at other pharmacies. So they'll assist us in getting free drug for patients, letting us know that, hey, use Envarsus and their free month of Envarsus to get that first fill so that the patient doesn't have to wait for mail order. Same thing with Myfortic, patient assistance program for Valsite. So again, really kind of being the touch and go people with regards to getting patients out of the hospital with medications in hand. They don't do too much from a medication education perspective. That falls heavily on the pharmacist side. The pharmacists are the ones that meet with patients at discharge. We create their medication chart. We go over all of the medications and answer any and all questions that they might have about each individual agent. We actually have created a video also that we show patients while they're in the hospital. They watch them on their like MyChart bedside iPads that go over general counseling points so that when we talk to them at discharge, it's not like all fresh new information. But the nurses that we have are also instructed to go over the medications each time that they give them. So it's really that cyclical learning that, in my opinion, helps us out a lot when we do the discharge counseling, because it's not brand new information. The patients are already aware. We can do much more active learning with patients at that point, and we find that to be really, really beneficial. And then for any new readmission, any patient that gets admitted to any of the transplant services or even any service here at UW, a pharmacist is doing their discharge counseling. Of course, it's not as in-depth, but we are reviewing all medication changes, all new medications, and even reminding them of what medications to continue or stop on discharge.
Thanks, Dan. Amazing, just as I remember. How about you, Karen?
So similar to kind of what Dan is describing from an education standpoint, obviously the pharmacists are at the forefront of education when it comes to medication. But as I kind of mentioned, our discharge coordinator also assists with education. So our coordinator is in charge of kind of doing a lot of the lifestyle stuff and actually also does review the medications as well. So it's whoever goes in first, the second person will do teach back and ensure that the patient's actually retaining the information. We also recently just purchased videos that are, drug specific. So excited to be implementing that soon. I'm sure it'll make our lives a lot easier. And then from a med access standpoint, similar to kind of what Dan is describing, we do have a team of liaisons that are technicians that run all the benefits investigation for all our patients and are the ones who are primarily doing the prior authorizations for our patients. But I will say from, clinical perspective, sometimes we have to step in and provide that clinical, information that they need, whether it's a letter of medical necessity or documentation. Something that's also that they help us with that I think is integral is they actually look into, we do a lot of Hep C, NAT positive organ transplants. So they actually ensure that before someone is listed for Hep C positive, that they have some sort of drug coverage for a direct acting antiviral. So they're an integral part of that as well. But also from a medication access standpoint, we do have a pharmacy on site. So, the pharmacists will work closely with the liaisons to help us to ensure that we get all the medications we need. If we need patient assistance programs, then our liaisons help with that. And if we identify the need to fill at a specialty pharmacy, we'll, coordinate that as well. We still haven't been able to get any assistance with first fill overrides with specialty pharmacy. That's something that we're still trying to navigate, and it's definitely, a challenge. But other than that, I think it's similar to kind of what Dan was describing.
Awesome. And we're going to shift over to specialty next. Just a quick question. The videos that you guys require patients to watch those, I presume.
Mm-hmm. Yeah, they are required to watch it before they leave the hospital. And if they don't, they are doing it the morning of their discharge.
You give them like a quiz or anything?
We used to pre-COVID do it as actually a class where all the patients would get together. Because of social distancing. Now they do it individually at the bedside, so we don't have that opportunity to do the quiz. But that's definitely something that I guess we could implement and see if MyChart bedside has a way of doing like quiz questions or polls or something. I mean, if you can order your meal on it, you can definitely answer some questions on it.
Yeah, we're actually planning to integrate a Qualtrics with our video so that the video is embedded within a Qualtrics and then you can answer questions and then you can have them do it, whatever early on and then later on and see how they improve.
And then review with them, like when you do that.
Exactly.
Or they can't leave the hospital till they get a 90%.
Exactly.
Okay, thanks, guys. All right, we will move over to specialty pharmacy and insurance. So talk about what relationship, if any, you all have with specialty pharmacies to help promote transitions of care, and what your role is in prior auths and appeals, and if your team has a dedicated person to do this or a team to assist. And then what do you do for discharge when patients are locked into mail order for their immunosuppression and you can't do those overrides like Karen was just talking about. So we'll start with Dan and then have Justine jump in too.
Definitely. So we do have our own specialty pharmacy here at UW, which helps with a lot. So we're able to get medications to patients and mail them out to wherever they are, because we do have a lot of patients coming in from all over the Midwest. And it is a very close relationship. We can see their notes in our chart as well. So that helps us a lot with the EMR, and they can see ours. Getting refills is very easy because it just goes straight through Epic, and there's no need for faxes, phone calls, or any of that mess. So the coordinators really do appreciate it. And then, like I mentioned earlier, our technicians are the ones that try to get patients signed up for our specialty pharmacy at the time of their transplant, both to capture the patients so that they can fill their medications with us. But again, because we have that great relationship with them, it definitely ends up being in the patient's benefit, because we're able to keep closer tabs on what prescriptions they actually have ordered. We have Willow Ambulatory too, which we probably went live with in 2020. And that's been great from an ambulatory and even inpatient standpoint, because you can see exactly when they're filling things. You can see exactly what prescriptions they have and what they've been receiving. So if you need to send out refills or adjust things on discharge, you have a even better way of reconciling what they actually have filled at their pharmacy. And I would say with regards to the specialty pharmacy, again, I think patients really do appreciate it because they know that it is UW, and they have confidence in us because they came to us for our transplant. So I think that definitely helps patients as well.
Yeah, that's great. How about you, Justine?
Yeah, similarly, we have our own pharmacy. It's kind of, our specialty pharmacy is kind of carved out of one of our current outpatient pharmacies, and we have a dedicated team within that pharmacy. So they have a specific line that they call and specific people that they can ask for, so that they're not just asking for being taken care of by the general population folks that could be coming in and out of that pharmacy, as far as like new people, new hires all the time, and students and things. So that just ensures that they understand the gravity of missing doses, or if there's any problems, who to contact. And that's what they do. So I take care of all the refills for all the patients. I call it our VIP program, which is our very important patients. So it's our HIV patients as well as our transplant patients. And so they'll reach out if they need refills, and they use a product, I think it's called Health Cloud, through Salesforce, to reach out to patients on a monthly basis ahead of time prior to them needing their refills. They'll reach out to the patient, confirm how much they have left, and confirm their address and things like that, and mail them out. So that has been total game changer as far as coordinating. We make sure that we have the same manufacturer of tacrolimus, both on the inpatient and outpatient side. And I enroll all those patients in their first post-transplant visit. So I think I have like a 98% selling rate. It would be 100%, but there's just a couple people that require that they can't fill with us. So those are the people that I haven't been able to capture, but pretty much everyone else, once I say we take care of everything, it's like not a question. They're like, do it all, please take it.
That in a direct line, that's amazing. I feel like
we have a text, they can text us as well. They'll text my liaison as well if they need something, and they have my direct line too.
That's so cool. Do you play a role in doing prior auths? Dean or Dan, either? Sorry, go ahead.
We have somewhat of a role. They're initiated all by our technicians, and they also have the EPAs, which they can complete, which helps a ton, less paperwork, and some of it gets auto-filled. So I would say most of the prior authors come out of the technicians. Of course, if there's clinical questions or things that need clarification, we're definitely the point people for them, and they'll reach out to the pharmacists. But the PAs do come out of that PA team, and we have a team of 2 technicians for transplant, but then with different specialties, there are even more technicians to help out. For appeals, though, that does get a little trickier. The technicians will usually start the appeals, and then they'll reach out to us if more clinical information is needed, literature, notes, letters of medical necessity. Then we'll complete that part and hand it off to them to submit it, because then they'll be the ones to follow up on it, which I think is a great system for us. At least I don't want to be the one to have to contact an insurance or check the platform or be on the receiving end of a fax. So I really do appreciate their help with that.
Yeah, that's great.
Similarly, they pretty much, I have a dedicated pharmacy liaison technician that works in my clinic. And so she's there, she can see the computer system that they have when we're in clinic, so that she can check if there's any question about when a patient's last fill was or why they didn't get something. We can fill that, and she can also process the prescription from clinic so that it's ready by the time they're done with clinic, which has been fantastic as well. So prior authorizations as well, she completes on her own, as well as the appeal. She's been with me for about 7 years. And at this point, she is pretty much a miniature pharmacist. And so if she's not around, she has a couple other dedicated people that assist. And then they'll pull me in a few instances, but it's honestly very rare that I get pulled in to assist. She's been fantastic and works magic. I don't know how she does what she does.
It's great. And I know this is something we battle a lot, is with the mail order on discharge and overrides. And so wondering if either of you guys have any tips or tricks, or how you guys handle this when it comes up at your institution.
Kind of alluded to this already with my previous question, but the technicians are great at identifying different vouchers, coupons that we could potentially use to bridge them to getting their medications from their specialty mail order pharmacy. We'll also see if we can't fill it at our institution with an override, if we can get an override to fill out another local pharmacy that they can pick up, rather than having to wait for it to come in the mail. We do have a patient fund also that sometimes we'll tap into if needed. So donations from whomever go into this fund, and then we can tap into that to get patients bridge supplies. We'll also see if patients are willing just to pay out of pocket for a week or 2 of medications. And sometimes that tends to be the solution. But again, for some of the more expensive medications, we'll look at other options. And getting the patient assistance program, especially for Valsite, started early is probably one of the biggest roadblocks that we've identified. And being successful at getting that done ASAP, and the turnaround time for that has definitely improved patients being able to get medications faster at home also once they leave the hospital.
Have you ever gotten it completed before they left?
The Valsite PAs, PAP? Yeah, most of them. I would say probably 99% of them are completed before they leave the hospital.
Amazing. Justine, any?
Yeah, pretty similar. I would say the one difference might be that I don't know what, again, magic my liaison does, but the conversation that we essentially have with upper management is just whatever the transplant patients need, they can get. And so when it comes to having, an extra month, or something is lost, or they're locked into mail order and they need something, a lot of times it's just whatever you need to do. So I've been very grateful for their understanding and their support for that.
Great, thank you so much. Okay, so we're going to switch over and talk about weekends, and how you facilitate discharges from a medication standpoint on the weekend when the services may not be as robust as they are during the week. So Justine, if you want to start.
So like I mentioned earlier, I don't work on the inpatient side, however, and we don't actually have a dedicated inpatient person anymore. So at this point, we have just kind of group coverage from the inpatient folks. And so there's always coverage on the weekend. They're usually doing a couple different touch points for education on the patients, and we use our discharge, our meds to bed program in order to get them medications on the weekend. That's open both Saturday and Sunday. It's the only pharmacy, so that's why we used that one. So we ensure prior to us having weekend coverage, it was just trying to get the education done on Friday beforehand or Monday. But when we were able to expand that coverage just throughout the hospital and then utilize them for our transplant patients, it also cut down on our, of course, our length of stays as well.
Thank you. Dan?
And we do have weekend clinical coverage at UW. There's a transplant pharmacist that works from 7 to 3:30, and occasionally there's a pharmacist that covers the evening shift, a transplant pharmacist that covers the evening shift, myself. Sometimes we have it up until 10 o'clock. But I would honestly say that the way that we work is we try to do as much before the weekend. So we do our discharge counseling on Thursdays and Fridays. We try to get prescriptions pended and medications reconciled before the weekend to help that one weekend person that has all of the transplant patients on the weekend. And then that also allows us to work with the technicians to make sure that we don't run into any hiccups, and we have a plan going into the weekend so that we know that the valsite's going to get shipped to their house and they're going to get it when they get home, or that we need a bridge supply, or that we need to send prescriptions to X, Y, and Z, because it is very hard to manage that by yourself on a weekend. So we found that communicating with the technicians before the weekend has helped a ton. And then if needed, and there's last minute discharges that left, we do again have a pharmacist who is available to do the work on the weekend. And then there is one technician that covers all of the services on the weekends as well, that if needed, we can get quick test claims done and prior authorizations if needed, but again, limited to what insurances are open and kind of able to communicate back with their responses over Saturday and Sunday.
Sure. Great, thank you guys. Okay. Ooh. And then for Justine and Karen, we'll talk about some non-transplant meds. We know our patients often have follow-up for many other comorbidities or specialties, whether it be endocrine or pain or cards, and there can be a gap in getting them an appointment. So how have you guys helped bridge that gap when patients may come to the transplant clinic with any issues pertaining to these specialties or their meds prescribed by the specialist? So we can start with Justine.
Yeah, I think that this is where my ambulatory care side kind of kicks in a little bit more. Previously, I was doing a lot of diabetes management. Unfortunately, my providers don't manage diabetes at all, and they're allergic to managing it. So I can't utilize that skill anymore. But I just did this past week. Patient didn't understand, wasn't sure. It was kind of unclear about how, if they were using their insulin pens correctly. So I just, waltzed in with my insulin pen and pen needle that I have in my backpack, because that's who I am, and asked him to check it, how he was administering it, and come to find out he was not taking off either of the safety caps on the needle, which is why his blood sugar was still in the 250 range. So I think that having that ability, or the ability to know how to check teach a glucometer or a new inhaler, things like that, is just part of being a pharmacist in a clinic, that I am able to kind of flex that muscle every once in a while. Not often anymore, but as much as I can, I try to touch base.
That's great.
I would say similar from a diabetes perspective, early after transplant, especially for seeing like steroid-induced hyperglycemia, we actually work with our discharge coordinator to make sure that these patients are taught how to check their blood sugar, how to administer insulin, and we do plug them in with endocrinology, but we have to kind of bridge that gap in the meantime. We actually will sometimes have them practice while they're in the hospital and verify it. The insulin pen as their own medication so that they can practice while they're here. I would say, just in general, when a patient comes in for transplant, obviously we have to look at everything holistically. So, looking at all their other medications, I would say the biggest thing that comes up often is, from a cardiology perspective, they had a stent, they're on dual antiplatelet therapy, we held their Plavix. So something we do is we actually, during their index transplant admission, we will make sure to touch base with those specialists, especially if it's cardiology, just to kind of figure out what the plan is in terms of dual antiplatelet therapy and or switching them to monotherapy. And if we don't, we'll come up with a safe plan until they have their next follow-up, and that will be for other specialties as well. But I would say from glycemic and cardiology, those are probably the two biggest things that we run into at the time of transplant. But I would say similar to any other, non-transplant related medication.
Thank you. Yeah, I think we all face this all the time. Okay, so just want to make sure we stay. Sorry, I muted myself. So for Kristen, one thing I'm really interested in is for FTE expansion, what your experience has been with working on approval and justification for additional pharmacy support to help with some of these transition of care activities that we know take up considerable amounts of time. Uh-oh. Kristen, are you there? Oh,
yeah, I apologize. I'm having some internet issues. So if I cut out, just let me know if you need me to repeat anything. Can you hear me now?
I can, yeah.
Okay. So in the last year, we actually were able to get 2.5 pharmacist FTE and 2 pharmacy technician FTE approved. I will preface this though and say that there's a huge push right now in our health system to expand our ambulatory pharmacy. So we kind of almost lucked into this a little bit. The other thing that is to our benefit is we've just rapidly expanded our heart transplant program. So we really had a lot of push from not just pharmacy, but transplant leadership too, that they really wanted these positions. So when we did our business plan for these positions, we really focused on trying to optimize the number of pharmacists for our current workflow. So we called it like right sizing our transplant pharmacy program. So what we did is we did pretty extensive time studies with our renal transplant pharmacists, looking at the activities we're doing, time spent per patient, and then looked back at number of transplants we've done over the last 5 years and created basically these pharmacist to patient staffing ratios that we need to satisfy what we're currently doing. And based on those ratios is what we use to justify these extra positions. So that was kind of the main part of our business plan, trying to show that we're not actually staffed appropriately for what we're doing right now. And then the second thing we focused on was additional value added services that we can do. So incorporating more pharmacogenomics, incorporating more pharmacy med-rec in the clinic. And then on the kidney side, we currently manage all the refills for the transplant center, and then any pharmacy medication related phone call that comes into the transplant center during business hours is triaged to us as well. So we built that into the heart side to kind of incorporate more services on their side too. And use current transplant literature, pull some of our own internal data. So we have 2 kind of published things that we've done looking at our transplant pharmacy services. So the first is looking at incorporating pharmacy med-rec into clinic. And that was from one of our previous residents, Danielle McKimmey, did a pilot study comparing pharmacy med-rec versus standard of care, which for us is our nurse coordinator, who's an RN, doing the med history, and then the provider reconciling it. And we found with pharmacy med-rec, we reduced errors from over 90 had an error on the med list to less than 30% and our products. So the patient just didn't know how to report it. It says my internet's unstable. Are you still able to hear me?
It's kind of going in and out, and we missed bit, like you reduced from.
Oh no, okay.
Yeah.
So it was over 90% of patients had an error, at least one. and we reduced it down to 30%.
Wow.
And most of those errors were either an OTC med that the patient just didn't know, or it was a TAC dose adjustment that happened after the patient saw the pharmacist, so it was counted as an error. And then the second thing that we looked at was our hyperglycemia management. And so one of our previous residents prior to our collaborative practice agreement, a cohort of patients after. Can you still hear me? Oh no.
That went out a bit. It was one of your previous residents for the
Okay.
hyperglycemia.
So we looked, yeah, Vincent Doe looked, yeah, he looked at patients before and after we implemented hyperglycemia management, and we significantly reduced ED visits and hospitalizations. So in the last 5 years, I can probably count on one hand the number of patients we've had admitted for a hyperglycemia event post-transplant within the first 3 months. So we also included our own internal data in that business plan, which helped. So I'd say it was a combination of justifying it using what we've done, but also a little bit of luck of what the health system wanted at that
Sure.
time.
That's awesome. Thank you so much for sharing that. I think the hyperglycemia management is huge. All right. Well, I think we're kind of near the end. The last question, which is for all of our panelists, or any specific challenges and successes that you've experienced when transitioning a patient. I'm gonna start with Karen.
So I'm sure we'd all kind of agree, but I would say, some of the challenges that we've had is just a matter of resources. So it was only a couple of months ago that we were actually able to expand into the clinic. So that will definitely help with our transitions of care. Previously, all of our communication and all of our transitions of care plans for our patients was communicated to our nurse practitioners, but now having kind of pharmacy presence there would definitely make that a little bit easier, just because our NPs are already very overwhelmed in the clinic. I think things that definitely increase success is going to be proper communication and making sure that we're documenting and kind of facilitating that transition from inpatient to outpatient.
Okay, Kristen.
If you want to move on from me, I'm just going to type it in the chat because I'm worried my internet's just too unstable.
Okay, sure. Marissa?
Challenges, I think, for us are, despite the centralized care everywhere system that we can utilize, there's still multiple providers sometimes, or maybe outside rush network providers, and that lack of communication that Karen kind of alluded to, or varying healthcare access points that sometimes things just get a little muddled. So I think documentation, keeping streamlined is important. For successes, I think communication, as Karen said, is key, and education is key. Having patients play a dedicated or active role in their health, even from a pre-transplant process, whether it's utilizing the importance of a med action plan or a med list, reinforcing how important medication compliance is at each care index or visit, getting them ready for the idea of specialized care versus maybe the primary care that they're used to. Just playing really an active role in their health is, I think, the future direction we're going.
Thanks, Marissa. How about you, Dan?
I think both the challenge and success that we've identified is finding support for patients. I think they are much more successful when they're not doing it alone at home. So we've definitely been working with our social workers to help identify a point person that can come to their appointments with them, that can be present at their discharge counseling and review the discharge education with them while they're in the hospital too, so that they can both be educated, but then also ask questions because they're going to help the patient out at home. So I think that has been probably one of the biggest things, so that the patient also feels support in their own home space while going through all of these changes, which can be most definitely overwhelming.
Great, thanks. And Justine?
Yep, I would agree with Dan. A lot of our patients, we've a large population of undocumented patients, and a lot of them, their support person might not be in the country or maybe in the country temporarily and then leave. So making sure that there's a dedicated support person that's going to remain throughout not only the pre-transplant but post-transplant process, and that is dedicated to them as a person, and it's not just like a friend, a neighbor, or just somebody to make sure that it's filling that position, is sometimes really hard for them to identify because they came here with nobody. The other thing I think both challenge and success that I've had relating to our patients is just the wide variety of languages that our patients speak, and are probably many times unable to read. So we've used a lot of different ways in order to ensure that they're able to understand their medications, specifically like using different kinds of stickers, like lions and hippos and books and starfish and all these different things in order to make sure it matches on their med list and their bottles. And it has it in the SIG code so that when they call for refills, they're calling for their whale or their hippo, and it works for the pharmacy and it works for our patients, and they're able to fill their pillboxes accurately, which they weren't able to do prior to that. So a lot of creativity and success that has happened through that, and I think that that's been able to ensure that they continue to remain doing well post-transplant.
And empowering them, which is so great. So that's wonderful. And then Kristen commented in the chat for successes is an increased number of patients they're able to follow using those my lists and handing off effectively between inpatient and outpatient to better track and follow patients. And then for challenges, identifying patients who develop issues later on in clinic, and then relying on a nurse or provider to identify issues like hyperglycemia and reaching out and then referring them to the pharmacist. And then there was a question that was sent to everybody, but I'm interested too. If anyone does start Valsite prescription assistance pre-transplant, like during the pre-eval or that interval or review that you guys, I know Marissa talked about, and we find this too, the significant delay of application processing due to the need for brand and especially if you're doing it on your own. So wondering if any of the panelists have any input on that.
I'll admit, I don't see delays with the Valsite PAP. I don't know why, didn't know others were. We do start it in the pre-op visit for our donors, so it'll be like 2 to 3 weeks before. But even for not our donors, our living donors, God. But for the deceased donor recipients, we do start them while in the hospital, and we do get it approved. We do have one provider that has completed one of the provider form and is signed. So we'll utilize that form for every single patient so that we can get that completed ASAP. So then all we need is just the patient's signature and the patient's annual income when we submit the PAP, which is only 2 pieces, and the patient's not going anywhere but the hospital bed. So we can run over, grab that, and then submit it right away.
Great, thank you. Does anyone else start at pre? No? Okay, sounds like no. All right, well, that's all the questions, and I know we're a few minutes over, so thanks everybody. Thanks to all of our wonderful panelists for all of their valuable information and tips, and for everybody who joined us today. Hopefully this was beneficial for you all, and it was really great for me to listen to everybody. So thank you so much again, and this will be posted on the YouTube, and have a great Tuesday night, rest of your week. Thank you.